This study was done in Dr. R.P. Center for Ophthalmic Science. It is an ambispetic comparative study with a duration of 18 months, and 10 patients were included in a bevacizumab group, and 10 patients were included in without bevacizumab group. That is the retrospective patient, the early patient, where we have not injected the bevacizumab to prevent the macular edema or radiation retinopathy, and ethical clearance were obtained. So we had a three group. One is a prospective group. Where the patient was selected as per the inclusion and exclusion criteria, and pre-op all the evaluation were done, and patient was posted for plaque brachytherapy, and first dose were given at the time of removal of plaque brachy, and second dose were given at second month, and the last dose, the third dose, were given at 4 months, and all the parameters which were included in the study were done at second, fourth, and 6 month respectively. The retrospective group were the earlier cases of UL melanoma who underwent plaque brachytherapy in the past 1 year without prophylactic intravitreal bevacizumab. Patient demography and clinical data were retrieved from the hospital admission file, and the record of tumor response on USG, visual acuity, and tumor-related complication were noted at 1, 3, and 6 month follow-up, same as in IVB group. And the control were the fellow eye of the bevacizumab group. So we compared all the parameters in the on OCTA and OCT and ocular USG, and compared with a proper statistical analysis. So results, patient demographic and baseline parameters were comparable. So when we compare the bevacizumab and non-bevacizumab group, we found that there was increase in FAS area and FAS perimeter on follow-ups. However, ETDRS vessel density and peripapillary capillary perfusion were reduced in non-bevacizumab group. At 6 month post-op, there were percentage reduction in ETDRS vessel density. There was 12.5% decrease, and however, in non-bevacizumab group, there was 52% decrease in the ETDRS vessel density. Same, there FAS area was more decreased. FAS areas were more increased in non-bevacizumab group, and perfusion was decreased in non-bevacizumab group. So this is the OCT angiography on CRS HD OCT. So we can see there is increase in FAS area and cystoid macular edema in the non-IVB group at 6 months. This is the pre-op and the post-op brachytherapy OCTA imaging at 6 months in bevacizumab group. We can see there is almost same 0.45 versus 0.45 area and FAS parameter. And when we see the tumor dimension, there was decrease in tumor dimension both in bevacizumab group and the non-bevacizumab group. And there was no vision-related complication with the bevacizumab group or with the brachytherapy.
You can conclude, Dr. Hussain, your time is
Conclusion, there is enlarged FAS area and perimeter. There is decreased peripapillary perfusion and flux index in non-IVB group. Decreased vessel density in group without IVB, and 100% globe salvage rate were seen at 6 months. So where our recommendation is OCT can help in diagnosing early preclinical radiation retinopathy in post-plaque brachytherapy in uveal melanoma. Prophylactic IVB intravitreal bevacizumab post-plaque brachytherapy can help in preventing radiation-related retinopathy in post-plaque brachytherapy in uveal melanoma. Thank you.
In that one slide, you showed that the difference in this reduction of the tumor of the two groups was also quite a big of a difference.
No, so it was in bevacizumab group we compared at 6 months. In non-bevacizumab, they were the older patient where the reduction was noted at 1 month. We collected the data 1 year. So there was a difference at 6 months in bevacizumab group.
Can you put his slide? Yeah.
Yes. There is a reduction at post of 1 year in non-bevacizumab group. So this was not in our primary objective, so that's why we just gave a...
yeah, but I'm wondering what accounts for the reduction of almost 30% in the retrospective group and half of that in the primary.
Sir, that is most of the plaque brachytherapy, we have seen the effect at post of 3 months, which continues 2 or 3 years. So in this case, we are actually seeing a post of 6 months in bevacizumab group. So bevacizumab has no role in the reduction of tumor dimensions. It's actually the time duration. We are actually showing the time duration. That is in the post of 1 year, there is reduction by
Got it.
30%.
Dr. Hussain, so you might have to revise the title of your study. So what you are actually comparing what you're actually comparing is the characteristics of the vessels post radiation in anti-VEGF group versus non-anti-VEGF group.
Yes, ma'am.
So we are not only looking at radiation affecting radiation retinopathy, but also the treatment.
Exactly.
So you might have to revise the title of your paper. It's a little misleading.
Ma'am, actually, it's a quantitative. We are actually.
Though it's a quantitative analysis, the groups are different. It's not only the Prague brachytherapy you're measuring. You are already measuring the effect after anti-VEGF in a group and without anti-VEGF. So anti-VEGF is a confounding factor for radiation retinopathy.
Agreed.
I'm sorry, I can't. I think it's not clear.
So the anti-VEGF.
See, your intervention here is also, apart from plaque, is bevacizumab.
Yes, ma'am.
That's not even there in the title. So it's a comparative quantitative study of retinal circulation based on OCT after plaque brachytherapy in uveal melanoma, with and without. So it
this is the,
okay. So the title that we got is not
It's about because the letter limit was limited
in this is
exactly.
Okay, that's why.
Yeah.
So the copy that we got didn't have the entire title. Okay.
Because of
we'll move on
alphabets, there was limitation of
Thank you.
alphabet.
Dr. Vindhya.
Thank you.
Is Dr. Vindhya there?
Yeah.
Okay, then we move to the next speaker, Dr. Shefali Chahar. So if speaker is not there, then we have to mark them no. And then this goes.
Common instructions for all the presenting authors, please keep to your timings, and that is 5 minutes for the entire presentation. Go ahead.
Good afternoon, everyone. Thank you so much for this opportunity to present my study titled Survey of Orbital Tumors in Elderly Population. It's a large case series, and I'm thankful to my mentors for their constant guidance. So orbital tumors, orbit, as we know, it has a wide range of structures present there, and which can be site of origin, any of these structures. Based on the origin, we can have either a primary tumor, secondary tumor, or metastatic tumor. Based on the nature, it can be benign or malignant. Based on morphology, it can be well encapsulated or diffuse. So when we have to diagnose orbital tumors, surgical biopsy is the gold standard. It can be either incision or excision, but there are other modalities of treatment also. This is a classification proposed by the Shields group, which is a very systematic classification according to the structures present and what tumors can arise from that. And we have used this classification to categorize the tumors in our study. So when we look at the review of literature and the prevalence of space-occupying orbital lesions, there is a large variability that exists in the surveys. Why? Because it depends on where the data is coming from. Is it coming from a clinical ophthalmological clinic or an ENT-associated ophthalmology clinic or a surgical orbital biopsies? The age can also vary it, and the geographical location. And of course, limited information is available about the spectrum of orbital space-occupying lesions in senior adult populations in India. We know it is a diagnostic dilemma. We know it is a challenging situation. So we need to have a correct and timely diagnosis to avoid unnecessary investigation that we make the patients go through, and also the unnecessary procedures and treatment. So we have to have a good knowledge of the spectrum that exists. So with this aim, we wanted to analyze the spectrum and the management outcomes of these orbital lesions in elderly population, specifically in the age group of 60 and above. So it was a retrospective consecutive interventional clinico-pathological series, and we had a total of 223 cases. All of them underwent a thorough clinical examination, a radiology, either with a CT or an MRI, and surgical histopathological proven tumors were taken in the study, and sample was sent for histopathology, and management and outcomes was studied. And the same surgeon did the surgery, and pathologist was also same, and diagnosis was made in all the cases. So we had a median age of 65, and I've shown the age range here. Mostly fell under 60 to 70 age group, and males slightly predominated more than the females. Bilaterality was seen in 9% of the cases. Most common presenting symptom, clinical feature I would say, was mass and protrusion, followed by protrusion and diminution of vision. And when we took the history, 3.1% already had a systemic malignancy. Tumor characteristics, we have studied it in detail, but most common was a firm mass, which was diffuse, heterogeneous, and present from anterior to mid-orbit. And histopathology for the diagnosis, the approach was, of course, according to the position of the tumor. The primary treatment was maximum incision biopsy in most of the cases, followed by excision. Interesting thing to note was exenteration was more common probably 10 years back, and it kind of like decreased as the data went along, because it is a 20-year-old study, a 20-year study period. And this is the data that we found. Most common lesions were lymphoproliferative. I have just noted down the most common ones from each category, and I'll be showing it in a separate table. But I would say this is the most important slide from my presentation, and the take-home message that 65% of the lesions in this set of population were malignant lesions, and only 35% were benign. This is the top 3 benign and the malignant lesions that we found in our survey. Additional treatment had to be given according to the pathology of the tumor, and median follow-up was of 4 years. Another important thing to note was metastasis that we found as we followed up the patient. 9.5% had a systemic metastasis in the follow-up period. So that is also important to remember, because these need continuous follow-up throughout lifetime. Final outcome was unknown because of loss to follow-up, but most of the cases were alive and did well. So this is my survey and the table that I made according to the tumor types and in detail the survey that we found. So I would say there is increase in the longevity as is seen in the country, and this set of population is increasing. Another challenging thing in this set of population is they have a resistance to seek healthcare, and they need less downtime, and tolerance to treatment is also less. So we need to be accurate in our diagnosis. This is just a case to show that we thought that it is a lacrimal gland tumor, which proved to be so, but a systemic evaluation was required, and it was a rare kind of a lacrimal duct carcinoma. These are the other surveys that exist, and another one from the senior author, and our findings were corroborative with this study, malignancy being predominant and lymphoma being predominant malignancy that was seen. So I would just like to conclude by saying that it is imperative to know the pattern of frequency of distribution of these tumors to make the correct diagnosis, and it just highlights the different pathologies that can exist, and it is prudent to keep malignancy in mind when we are dealing with this set of population. Thank you so much. These are my references. Thank you so much.
Nice presentation. I just had a question. You've had this data collected over 20 years.
Yes,
and especially with lymphomas, I'm curious whether the rate of lymphoma has changed over the years.
So the
Have you
most
looked at that?
So lymphoproliferative predominated, and the most common always throughout the study was ENMZL, followed by follicular, as is like
So
known
the
in the literature.
question was actually the rate. Has that changed? So have you been seeing more tumors in the recent years compared to, let's say, the first 10 years? Was there any difference in the rate
only
of tumors per
specifically
year?
to lymphoma?
Yeah, the lymphomas or any of the other tumors. As you know, the rate of lymphoma worldwide globally is increasing. And so I'm wondering if you found the same thing in your study.
So I have not compared it with the old data, but probably I can look into it, like how with the IHC and everything, it has changed over the years.
So exactly on that point, if you could create a split of the first 10 years versus the next 10 years,
Correct, yeah.
and look at the change of proportion, that will tell you, couple of things. One is mean age at diagnosis in terms of malignant lesions, and the proportion of whether, say, lymphoma has increased or not. The other question I had was, Richard Allen in one of his talks on orbital mets says that he has a very low threshold for suspecting malignancies, and says a patient above 60 with an orbital mass is near almost always a malignancy. Did you have any proportion, any kind sort of a similar kind of observation where beyond a particular age, the proportion of malignant tumors was greater than that of benign tumors, or any sort of age-wise description in age-wise split or comparison?
I did not, in the age range I have not done, but we have a similar concurrent study that is done by another fellow, which sees the pediatric population. So that definitely proves that their benign tumors predominated, and in my series 60 above, malignant tumors predominated, like with the majority of the ratio.
Thanks.
Thank you, Dr. Shefali. That was a crisp presentation. I would like to invite Dr. Deepti. for her paper on risk factors for local tumor recurrence and metastasis in sebaceous gland carcinoma of eyelid.
Can you start?
Good morning, everybody. My study is on risk factors for local tumor recurrence and metastasis in sebaceous gland carcinoma of the eyelid. So SGC is the most common eyelid malignancy in the East, and the incidence in India is twice that of what is seen in the West. And it is also misdiagnosed in up to half of the cases and are operated suboptimally before they present to a specialist. And aptly called the Great Masquerader, SGC comes in all shapes and sizes. At times they are hidden in plain sight like this, that you see only while everting the eyelid, but more often than not they present as chronic conjunctivitis, irregular pagetoid patch, or an unsuspecting nodule as of a chalazion. So the treatment patterns vary between clinicians, and the rates of recurrence and metastasis is varied, with those in the developing countries being more than twice as those of the West. And this could be due to higher incidence of SGC among our population, but it is crucial to know the risk factors that cause metastasis and recurrence. So there are many postulated factors, and the ones that are most consistently reported to be independent risk factors are pagetoid spread, canthal involvement, and a size more than 10 millimeters. So our study aimed to describe the clinical profile of SGC and the risk factors for local recurrence and metastasis in a single center with standard treatment protocol in a large series. So we did a retrospective analysis of about 183 patients histopathologically diagnosed with SGC operated at a tertiary eye care center. So the standard treatment for resectable tumor involved wide local excision with 4 millimeter clinically clear margin with map biopsy and intraoperative frozen section, followed by either direct reconstruction or a Tenzel's flap or a Cutler-Beard full thickness sliding flap or Hughes tarsoconjunctival flap for lower eyelid defects. So the mean age was 57 years with a slight female preponderance, and the mean duration of symptoms was around 2 years. So over 60% had a prior history of surgical intervention with an average of 1 surgery per patient and a maximum of 10 surgical interventions before presenting to us. And excision biopsy was slightly more common than incision biopsies. SCC was found more in the upper eyelid in about 60% of cases. It was multicentric in about 3%, involved the phonics in about 7%, and caruncle in about 10%. And the most common AGCC stage was T2B. The largest diameter, either horizontally or vertically, was more than 20 millimeters in 36.6% of our patients. And the most common primary modality of treatment was excisional biopsy with clinically clear margin, along with intraoperative frozen section, and around 16% required excentuation. Map biopsy was performed in about 62% of cases, mainly when there was a clinical suspicion of pagetoid spread or when there were atypical features, although clinical suspicion was present only in about 55% of patients. And among these, pagetoid above the tumor was seen in about 8.7%, and pagetoid away from the tumor was seen in 4.3% of cases. And the median time to recurrence in SCG reported is 22 months, and our follow-up was about 25 months. 8 had pre-existing metastatic disease, so out of 175 patients, local recurrence was seen in about 14% and metastasis in about 5% of patients, and the mean recurrence-free follow-up was 16 months and 21 months for recurrence and metastasis respectively. So in a more relatable terms, the incidence rate of recurrence was 0.12 per person per year, and incidence rate for metastasis was 0.04 per person per year. And among the Mets, 50% was to regional lymph nodes and 50% to distant locations. And so these rates were much lower than reported earlier from our part of the world, and the death rate was about 1.6%. On univariate analysis, the risk factors for local recurrence were prior surgical intervention and longer duration of symptoms, and those for metastasis were higher number of prior intervention and longer duration of symptoms and canthal involvement. Histopathologically, the factors affecting local recurrence were pagetoid away from the tumor and lymphovascular invasion. And when I say pagetoid away from the tumor, it's not map biopsy positivity. It is on the main tissue specimen when you find epithelial involvement away from the nodule and not right on top of the nodule. And those for metastasis, apart from clinical suspicion of pagetoid involvement, it was lymphovascular invasion. And please note that map positivity was not significant in this particular cohort that we found. By logistic regression, the independent risk factors were lymphovascular invasion and pagetoid spread away from tumor for recurrence and size more than 20 millimeters for metastasis. Frozen section is important because we found just a higher number of recurrence in those who did not have frozen section, although it was not statistically significant. MAP biopsy, clinical suspicion was seen in 55% for pagetoid involvement, but was positive only in around 10%. So in conclusion, risk factors for recurrence and metastasis were identified. Frozen section is important, MAP biopsy is also important, but it might not have a high yield, so it's always important to look for pagetoid spread away from the tumor and deal those cases with caution. These are my references, thank you.
It's a great study. Just a quick question. MAP biopsy was done in all cases or in select cases?
Selected cases.
But the outcomes of the MAP biopsy was not used as an analysis in the factors that affected metastasis.
We did. So we did not find, we didn't do it, so we did not do it in all the patients, we only did it in those with pagetoid, clinical suspicion of pagetoid or atypical features of the tumor. But when we used that as a variable, we did not find that a MAP positivity was significant for recurrence. I think why that was is because of an optimal management. When we found a MAP biopsy positive case, we did treat with cryotherapy and topical chemotherapy adequately for those patients. That's probably why we didn't, they did well.
So was there any patient who did not have a MAP biopsy done, but who came back with metastasis or recurrence?
I'm sure there was. I'll have to look at the exact number. Yes,
Because
there
then
was.
that will be one of those cases in whom there was no clinical suspicion of
Right.
pagetoid, but still came back with recurrence.
So in comparison to the other larger study, Dr. Shields' series, which looked at the risk factors, did you find any different factor, or your findings corroborate with the already published studies?
So the most important thing we found was this pagetoid away from the tumor, which is not really described. We always talk about size, MAP biopsy, but in the main tissue specimen, it's important to look at the epithelial involvement. It might imply that the epithelial involvement might be more focused around the main tumor, which might be missed when we do the standard MAP biopsy sites.
Sure, great, thank you. All right, that will be all. Thank you. May I invite next speaker, Dr. Rahman, to talk about deep learning-based identification of ocular surface squamous neoplasia from ocular surface images.
Good afternoon, everyone. I am Obaidur Rahman, and I am going to present my free paper on deep learning-based identification of ocular surface squamous neoplasia from ocular surface images. I have no financial disclosures to make. OSSN is the most common conjunctival malignancy in India, and it is a tumor which is visible on the ocular surface and can be imaged very easily. But there are a plethora of ocular surface conditions that might mimic OSSN, especially an early OSSN, and untrained eye may miss early signs of OSSN. So artificial intelligence has already been extensively used in ophthalmology. There are already more than 3,300 articles on PubMed. But when you talk about the use of artificial intelligence in ocular oncology, these articles are only a handful. So the purpose of our study was to apply artificial intelligence algorithms on slit lamp images and explore the utility of AI in differentiating OSSN from non-OSSN. That was a binary classification. And then differentiating OSSN from other surface disorders and normal images. So for this study, slit lamp images were retrieved in a 10-year period and was divided into 3 different data sets. One was HP proven or clinically diagnosed OSSN. The other was surface disorders other than OSSN, And the third group was the normal eyes of the patients without any ocular surface disorder. So any unclear photos and patients with ambiguous diagnosis were already excluded from the study. And photographs with a minimum resolution of 1024 by 1024 pixels were included and then resized to a standard size and divided into two broad groups, OSSN and non-OSSN. And then non-OSSN group was again subdivided into other disorders and normal. So data augmentation was performed in this study to rule out any bias of training and for more equitable distribution of data. And then this data was divided into training and testing sets. And then 3 different deep learning algorithms were applied on this data. And then the characteristics of the binary and the ternary classification were studied. So these were the different techniques by which data augmentation was done. So a total of 159 images of OSSN were included. And the combined non-OSSN group had 450 images. So for a more equitable distribution of data, some augmentation was performed and a final data set of 416 OSSN and 415 non-OSSN was achieved. So this is a heat map showing how the AI picked up OSSN lesions in patients. And these were the 3 different models that were used: MobileNet, Exception, and DenseNet. So binary classification divided these groups into OSSN and non-OSSN. And although the performance of the 3 models was somewhat similar, but MobileNet had the highest sensitivity in screening OSSN from the non-OSSN group. For ternary classification, again the characteristics of the 3 different models were similar, but MobileNet again was the best performing model. So the strengths of our study is that this is the first study in literature to utilize AI for OSSN detection from external photographs. We had a robust sample size. We maintained equitable distribution of images in each group to remove any kind of training bias. There was standardization for resolution and size. And without any data segmentation or data labeling, AI could detect OSSN from non-OSSN group with good performance and had an excellent binary distinction. There are some limitations to the study. One is there was no standardization of gaze, so the photos were in different gazes because of the different locations of the lesions. And ternary classification characteristics were not as good as binary classification. So to conclude, AI is a promising tool for OSSN detection from slit lamp photographs. Without any data segmentation and data labeling, it had a good performance in screening OSSN. And further refining of AI models can be done, and they may be useful for screening and referrals. So this was a preliminary study, and there are future directions to take from this study. The first one, of course, being that we have to further enhance the strength of this study by increasing the sample size, including photos in all gazes for all 3 different groups. And data labeling of structures and the lesions may improve the characteristics and performance of the DL models. The second one is that we plan to further refine this model and then test them on mobile phone photographs. And then finally, the ultimate goal is to bring research to clinics so that clinicians can capture photos, upload them on phone-based or web-based applications for screening of OSSN, monitoring, and referral from peripheral areas and from community. Thank you.
Yeah, can I? Hello.
Yes, sir.
You were you say there's no standardization of gaze, but what about the photographs itself? Like, how did you standardize the photographs?
Yeah. So photographs were standardized for upper lid margin, lower lid margin, and the area in between.
But,
And
did you use any like particular software to crop the image at the correct points and?
It was manually done, sir.
Huh?
It was manually done.
Okay.
Initially, we had planned to crop it with the software of ImageJ, but we were not getting the desired results, so then we performed manual cropping. And images that were too magnified, not showing the eyelids, they were removed then.
And was the images taken prospectively or retrospectively?
Retrospectively, sir.
So I think if better study would be you take it prospectively,
sir.
and
Exactly.
so that you can
So use
standardize
this
for both
model
the
to
gaze as
validate
well
it.
as the photograph.
So we're already doing that, sir. But since we wanted a larger sample size, so we had a 10-year data in our slit lamp already. So we took out from the slit lamp bank. But we are already enrolling more patients, sir.
Nice study. I was curious, did you do a predetermination of sample size, or you just took all takers?
Sir, so for AI, as much data as you can feed to the AI system becomes better and better. So
Yeah.
there was no determined
So
sample size.
that is what you had available for. to
Yes, sir.
study. Okay.
So,
The second question was, the rates are about 88%. What were the type of photographs that the machine learning got confused? Where was the errors? What type of lesions did it misdiagnose?
yeah, so sir, we went back to some of the photos that the machine could not understand. So, some of those photos were early lesions that were very close to maybe a pterygium, and even some of the normal photographs had been misdiagnosed. So that is something we are again trying to refine.
And
Go ahead. Did you calculate the area under the curve for these?
Yes, sir, we did, but I have not included it
Include
here
that in
because of the
data,
paucity of
okay.
time.
Okay.
But we have done that, sir.
And what are the criteria that you use for the computer to learn whether it is to differentiate between pterygium or a recurrent pterygium or and then OSSL? Are you
Sir, no
feeding them-
criteria was used since we did not perform a data labeling. So first we wanted to see if, without giving any input from the human side, can the DL model detect OSSN? So we are still to do that, and one of the things that might further refine and increase the performance is data labeling.
Thank you.
Madam. Please.
Please proceed, ma'am.
The mic is not on.
This is on sequential molecular screening methodology for the diagnosis of retinoblastoma. The diagnosis of retinoblastoma is often clinical. Radiology provides presumptive diagnosis. Histopathology can give a definitive diagnosis. Sequential molecular screening of RB is available only in few centers and is expensive, which remains a bottleneck. Hence, we aim to develop an indigenous and cost-effective method for the molecular diagnosis of retinoblastoma. DNA is isolated from the blood and the tumor samples wherever available using the suitable kits. The quantity and the quality of the isolated DNA is checked with qubit fluorometer and the agarose gel electrophoresis. Sanger sequencing and multiplex ligation dependent probe amplification, that is MLPA, is used to detect the point mutations and deletions duplications of the RB1 gene. Both the steps involve the amplification of the gene or the probe that binds to the gene, which gave us about 90% sensitivity. In addition, we do methylation specific MLPA for detection of the promoter methylation in RB1 gene, which gave us a 95% sensitivity. The next generation sequencing methods for the targeted whole exome sequencing were also done to detect the single nucleotide variations, that is SNV, and the copy number variants in additional genes other than the RB1. Library preparation using the specific kits was done at our own center. Data analysis was done as it is critical to identify the suitable variants. So this is the sequential molecular screening methodology and the instrumentation required for performing this task. And with all the methods and high throughput instruments in place, we complete the analysis starting from sample collection to report generation in just 3 weeks. The genetic analysis and counseling benefited 543 families with retinoblastoma. Patients with mutations, that is germline, were 305, formulating about 56%. Patients without mutations, that is sporadic, was 238, which was about 44%. And families with mutations were about 41, forming about 7.5%. If germline, their future siblings and offsprings have to be checked clinically and genetically. If there's no mutation in blood, it will not be inherited, is the inference. More than 100 mutations like nonsense, missense, frameshift, splice have been identified, out of which 20 are novel, and these mutations are being characterized for their pathogenic role. So there are some epigenetic factors as well, that is the promoter methylation analysis by MS-MLPA. The promoter methylation was identified in 4 of our patients, tumor but not in the blood. So this epigenetic event is somatic, which means there's less likely preponderance to inherit the mutation to the next generation. So you can see this particular scenario in the promoter region, there is methylation. It's a unilateral RB without any family history. This child had the mutation. So MICN amplification and RB tumors is another entity. The MICN is a well-characterized gene for RB. It is increased copy number of MICN has been found in many other cancers as well. MICN amplification with more than 10 copies was detected in 3 of our patients, correlating with the severity of the disease. So the copy number variations, analysis of unilateral RB tumor samples were validated and confirmed by the qPCR. Our next generation sequencing analysis has identified several candidate genes involved in the tumorigenesis. We found the gene amplifications of various genes, and these have been involved in the cell cycle regulation, cell proliferation and apoptosis. Currently, we are studying the role of individual genes through cell culture models and trying to identify the suitable drugs to reduce the expression. The impact of this study has been seen in many families where the timely and cost-effective diagnosis have helped them in making informed decisions. Cost has been reduced from $1,800 to $150 and the time from 10 weeks to 3 weeks. Thank you very much.
Thank you. Very interesting work and a very large data set. The question I had was the germline mutations. How many of those were new germline mutations in the family, or?
There were about 41 families had.
And the rest were all spontaneous new mutations. Okay, that's a large number of mutations. And have you collected samples for cell-free DNA also, or from the blood or the aqueous?
We have been trying, sir, but we've not been very successful in it. But we are planning to do it. Go ahead with aqueous and CSF as well.
Okay.
That's in the pipeline.
And there's a lot of data there, so I'm sure you will, at some point, correlate it to the clinical findings and other things. Okay.
Yes, and it's also, we're opening it up for other centers as well, for other patients through in the country. Thank you.
Good afternoon, everyone. My topic for today is clinical analysis of accidentally diagnosed lacrimal sac tumors post-DCR, a case series of 8 patients. I have no financial disclosure. Yeah. Is this okay? Yeah. These are my abbreviations used. So coming to the introduction, epiphora is the most common symptom experienced by most of the patients, and the most common cause of epiphora is pando. Pando is also associated with a swelling below the medial canthal tendon. Now, lacrimal sac tumors are rare, but without early diagnosis, they can be life-threatening. 55% of the lacrimal sac tumors are malignant, and they can be mistaken for pando and accidentally undergo DCR. Now, the purpose of our study is to report the outcomes of lacrimal sac tumors who accidentally underwent DCR. So this is the first of its kind of a case series, with prior only anecdotal reports have been reported in the literature. This was a retrospective study design. Appropriate approval was obtained from the ethics committee, and the consent was taken from the patients for the use of their data. The study period was Jan 2000 to September 2023. The inclusion criteria was histologically proven cases of lacrimal sac tumors who had inadvertently undergone DCR. A total of 8 such cases have been identified and included in the study. The outcome measures included tumor recurrence, locoregional lymph node involvement, systemic metastasis, and overall progression-free survival rate. Coming to the results, the mean follow-up period was 27 months with a male preponderance, and the most common age group we see this was 40 to 60 years, and it was all patients had a unilateral presentation, with the left side being more involved than the right. Epiphora was seen in all patients, and some patients presented with a swelling below the medial canthus, and some patients had a swelling extending above the medial canthus. None of the patients had any signs of systemic involvement. Prior surgical history, 4 patients had external DCR, 1 patient had undergone endonasal DCR, and 1 patient had a history of incomplete DCT followed by external DCR. The final histopathological diagnosis in these patients was 25% patients had solitary fibrous tumor as a diagnosis, 25% has diffuse large B-cell lymphoma, 25% patients had lacrimal sac papilloma, and 13% with transnational cell carcinoma, and 12% with mucoepidermoid carcinoma. So in our study, we had 50% patients with malignant tumor as a diagnosis and 50% with benign. In the malignant, the diffuse large B-cell lymphoma was the most predominant. It was interesting to note that a 17-year-old patient had had DLBCL and she had to undergo chemotherapy after DCR. So the final treatment given to these patients was exenteration with chemotherapy for the patient with mucoepidermoid carcinoma. The patient with diffuse large B-cell lymphoma underwent debulking chemotherapy along with radiotherapy. A patient with transitional cell carcinoma had to undergo DCT along with adjuvant radiotherapy, and the patient with benign tumors had to undergo DCT. The final outcome in these patients was 6 patients had a disease-free survival with a mean follow-up of 27 months. 1 patient with transitional cell papilloma had a nasal mass followed by an external auditory canal mass 1 and 2 years later respectively. 1 patient with a sinonasal papilloma was lost to follow-up. The red flag signs in our study was history of excessive bleeding during DCR, history of multiple failed DCR surgeries, abnormal bleeding of the sac seen intraoperatively, any swelling extending beyond the medial canthal tendon, and excessive swelling seen on postoperative day 1. Patient presenting with proptosis and dystopia is also a red flag sign. So coming to the discussion part, the lacrimal sac tumors are not common and they account for only 1.4% of duct obstructions which end up undergoing DCR. However, amongst these, 50% are malignant with peak incidence of 50 years. Lacrimal sac tumors can be divided into primary, secondary, and metastatic, and amongst primary, epithelial tumors are the most common. In our study, we had 25% of the patients with papillomas. In benign tumors, again, most common are papillomas with a tendency to recur in 10 to 40%, and this was comparable to our study. In malignant tumors, squamous cell carcinoma is the most common, but in our study, the diffuse large B-cell lymphoma were more common. So lymphomas account for 2 to 6% of malignant sac tumors, and they're frequently misdiagnosed as acute dacrocystitis, acute or chronic, and DCR with stenting is well tolerated in alleviating symptoms, but chemotherapy is a must for these patients. Concluding, the close follow-up is advised for patients presenting with medial canthal swelling extending above MCT, multiple sac surgeries or history of excessive bleeding, unusual appearance of the sac seen intraoperatively, unusually excessive swelling post-operative day 1, patient presenting with proptosis and dystopia. Imaging is necessary whenever suspicion arises. It is a good idea to examine the sac intraoperatively before we proceed with osteotomy. It prevents conduit formation. Any abnormal sac morphology seen intraoperatively, prefer going for incisional biopsy for histopathology guided management. DCT post-inadvertent DCR has an overall good prognosis and survival rate in patients with lacrimal sac tumors. These are my references. Thank you.
So in how many patients in the patients, most of the patients, did you begin doing a DCR, or was the sac incised, or?
So these patients, out of the 8 patients, 6 patients had come to us with a history of prior DCR outside. And they had epiphora, and we went ahead with an incisional biopsy, which turned out to be a lacrimal sac tumor. So amongst 2 patients, when we opened the osteotomy was already done, and we noticed an abnormal morphology. So this patient, again, incisional biopsy was taken, and then we found out that they were diffuse large B-cell lymphomas.
Great.
Thank you.
Right. Thank you, Dr. Saida.
Can I have my presentation, please? Very good afternoon, and thank you, AIOS, for letting us present our work on orbital lymphoma. This is a retrospective analysis of a large case series from a single center in South India. As we all know that lymphoproliferative lesions are common diseases of the orbit, with 67 to 90% of them being an orbital lymphoma, making it the most frequent and the common neoplasm malignant in the orbit in the adults, with the most common cell of origin being a B cell, and rarely from T cells or the NK cells. So it was a retrospective consecutive interventional case series analysis of over 20 years involving 171 biopsy-proven lymphoma cases, where our aim was to analyze the clinical profile, the clinico-radiological correlation, and a protocol-based management approach to these cases. As we all know that lymphoma has an insidious onset, as it is described in most of the literature works. In our series, we had about 80% of them presenting, but to our surprise, about 12% also had features of an acute onset. In our series, what we observed was that there was a lower age at presentation, about 50 years. As we all know, the literature points that about the disease belongs to the 6th to 8th decade of life, and like non-ophthalmic extranodal lymphomas, in our series we found a slightly higher male preponderance. How did they present to us? One is the prominence of proptosis in about 62% of the cases, then a mass in about 50% of the cases, acute features of pain in 20%, a reduction in the vision in about 20%, ptosis in 11% of cases, and a double vision in 6% with quite overlapping features in between them. Following the protrusion, the most common symptom was again a mass, and on our evaluation, about 75% of our cases had a mass which was palpable and was confined to the superior temporal quadrant of the orbit in 65% of the cases. Following this, we also noted involvement of the ocular muscles involving the superior rectus LPS complex and the lateral rectus, with the elevation deficit noted in about 60% of our cases. And as a part of the spectrum of lymphomas involving the mucosa associated lymphoid tissues, about 26 percentile showed involvement of the lacrimal gland. This is a CT image of the same, and the conjunctiva was involved in about 23% of our cases. Radiological evaluation and correlation showed non-specific features. However, what was interesting to note that there was a breach of the orbital margin with contiguous involvement of the paranasal sinuses in about 14% of the cases, and also an intracranial extension noted in about 8% of our cases. There was a 44% correlation between our preoperative clinical diagnosis and the histopathology. Depending on the clinical spectrum, those which were completely resectable underwent an excision biopsy, while the tumors which had a more diffuse involvement underwent a multi-level incision biopsy, highlighting the importance that the biopsy is taken from the epicenter of the lesion. What it showed on histopathology and immunochemistry and cytoanalysis, that primarily we had B cell and T cell, with the majority of them being B cell lymphomas, of which the most common was the extranodal marginal zone lymphoma, followed by follicular, followed by diffuse large B-cell lymphoma, and then the mantle cell lymphoma. This shows the extranodal marginal zone lymphoma with small to moderate sheet of lymphocytes. Next in common was the follicular lymphoma. It is interesting to note and to learn that follicles, though may be seen on histopathology, what really confirms and differentiates this from benign reactive lymphoid hyperplasia is that ensuring that the sampling is correct, and second is that it shows expressivity of the BCL2 protein. A mantle cell lymphoma shows positivity towards the cyclin D1 and CD5, cluster differentiation 5 expression. And a diffuse large B-cell lymphomas, they are associated with the poor prognosis, and those particularly with a high Ki-67 index. A few of the cases were T-cell lymphomas in our series, and we have the longest follow-up for our case to be about 8.5 years, and the arms of management include radiation and chemotherapy, with about 87.5% showing alive and well on follow-up. Here are a few examples of pre and post cases of lymphoma. Thank you.
What was, you said that the 4.4% odd had recurrence?
Recurrence, yeah.
At what duration after treatment did they have recurrence?
4.5 months is what we have seen in our series.
Okay, and this is 4.5 months after the completion of treatment?
Yes.
So that would probably mean inadequate treatment rather than recurrence, because I mean, radiation is itself spread out and chemotherapy is spread out so much.
I would partially agree to that, but I would have to always go back and look up.
Look at the data.
Yeah.
How long of a period? You have a large sample size. How many years was this?
This is over 20 years.
Okay. And I'll ask the same question I asked the previous speaker, but did you see any change over time? Or you haven't looked at that, whether lymphomas have become more common?
Yes, I take leaf out of Shefali's presentation where Dr. Akshay had suggested that we classify it 10 years and 10 years to look at the differentiation. Okay. We should do that. Yeah.
The other, you had several cases that were bilateral involvement in the orbit?
We had unilateral involvement in about 90% of the
Yeah,
cases.
and the 10% had bilateral?
Bilateral, yeah.
Did you do a systemic workup for all these patients?
Yes, sir. We do.
And what was the percentage? How many had other sites involved?
Yeah, 4% of the 4.9% of the cases had systemic involvement as well.
Thank you.
Thank you.
Okay. So next speaker is Dr. Ashwita Alva. Dr. Ashwita Alva is not here. Yes. You will be presenting from here.
A very good afternoon, everyone. Today, I'm going to discuss about the self-reliance and success story of the Made in India plaque brachytherapy, which was initiated by the Baba Atomic Research Center and coordinated by our mentor, Dr. Santosh Ji Honnavar. We have no financial interest. The journey of plaque brachytherapy starts way back in the 1929 when it was first initiated by Foster Moore, and we have only evolutionized since then. Ruthenium, having a longer half-life, being a beta emitter, produces increased dose to the tumor with reduced dose delivery to the normal structures. However, the exorbitant prices, multiple import restrictions made the availability limited. It costs about 11 lakh rupees to procure one single plaque. Thus came a necessity to provide something which is available for a higher number of population, increasing the cost-benefit ratio. Let me take you through the story of BARC. It was generated, rather say, the best was generated from the nuclear waste, and thus introducing the Make in India BARC plaque, both round and notched plaques. Only 1 cubic millimeter of the nuclear waste can generate thousands of plaques, and this, when surgically implanted at oncology centers, was assessed, and the safety and efficacy is what we aim to assess to see how indigenous these treatments were. It was a retrospective study, non-comparative interventional case series conducted from September 2020 to October 2023, where we checked the clinical and radiological assessment, the tumor dimensions were assessed, documented, and brachytherapy was planned. The dose, the size of the plaque, and the dosimetry values to the apex and the duration was calculated and surgically implanted. The patients underwent a regular follow-up. We totally studied 101 patients, where 70 received primary treatment and 31 secondary treatment. Both round and notch plaques was used, and a mean duration of 32 hours was given. The results was varied, with 25 patients of OSSN, 24 of choroidal melanoma, 21 of hemangioma, and 12 retinoblastoma cases. We provided an excellent vision salvage of more than 80% in choroidal hemangioma, retinoblastoma, and OSSN, with close to 60% of patients receiving excellent vision salvage. These are some outcomes in invasive ocular surface neoplasia, conjunctival melanoma, choroidal amelanotic melanoma, hemangioma, and retinoblastoma cases. An excellent tumor regression was seen in 90% of uveal melanomas and 100% regression in metastasis and OSS in patients. This was also comparable to the COMB study, ensuring 100% globe salvage with more than 50% vision salvage, making it a safe and dependable treatment. We abided by the guidelines to ensure a protocol-based treatment. Multiple studies have been performed, and the effectiveness of ruthenium plaque is comparable. However, what about the cost? What about its availability to multiple population? Is it only restricted to few? And thus, our study is one of the first to check the cost of it with a high number of cases, showing that we can be both safe and efficacious with providing 62% of vision salvage, 98% of eye salvage, and 100% of life salvage. This is one of the largest studies showing effective, self-reliant, and successful solution, ensuring both globe and vision salvage. Thus, there is increased availability and accessibility at only 5% of the cost. Indigenous made in India plaque brachytherapy has excellent outcomes, a cost-effective treatment useful for managing both intraocular and surface intraocular tumors, thus truly proving that the best can be made out of waste. Thank you.
Thank you. It may be prudent to highlight if there are any, weaknesses in the study. I noticed your mean follow-up period is 22 months, and the largest group of tumors treated is uveal melanoma. When we talk about 100% life salvage, we need to be careful in talking about it, because the mean duration for recurrence of uveal melanomas after treatment is around 30 months, which is less than the follow-up period of your study. So maybe a longer study and then a longer period, and then you could present the study.
Okay, sir. Thank you, sir.
Good afternoon, everyone. I'll be presenting a paper on under the title of histopathological and radiological correlation of optic nerve involvement in a case of retinoblastoma. Previously published studies have rightly highlighted optic nerve invasion as one of the most important prognostic factor in a case of retinoblastoma. So, NVI and secondary glaucoma are the clinical predictors for optic nerve invasion. MRI still remains the most widely used modality for optic nerve evaluation in preoperative cases. But does this MRI reliably predict optic nerve infiltration in all the cases all the time? To answer the same question, this study was designed. In a retrospective case series of 93 primary enucleated cases of retinoblastoma, after clinical evaluation, optic nerve invasion was studied on MRI T1 post-contrast scans, which was then compared with the results of histopathology. For this, we had expert radiologists and pathologists trained specifically for ophthalmology cases in our team to analyze all cases to negate the subjective bias. Let's go through some of the clinical case scenarios. A 4-year male child presented with a right eye leukocoria with focal NVI, secondary glaucoma. So, he was diagnosed with right eye group E retinoblastoma with clinical high risk factors. On MRI, there was no evidence of optic nerve extension, but to our surprise, there was a histopathology revealed 5 mm of retrolaminar optic nerve extension. So, here we had ONE on HP, but no ONE on MRI. Similarly, a second case presented with right eye leukocoria, diffuse ectropion uvea and NVI. So, a case of right eye group ERB with clinical high risk factors. Here, MRI showed 3 mm of retrolaminar optic nerve extension, but in this case, to our surprise, there was no optic nerve invasion. So, MRI showed ONE, but on HP, there was no ONE. In a third case, it was a 3-year-old male child with left eye leukocoria, group E retinoblastoma. MRI showed 7 mm of retrolaminar optic nerve extension, and histopathology, to our present surprise, it also showed the exactly same 7 mm of optic nerve extension. So, ONE on both MRI as well as HPE. In a fourth case, there was a left eye leukocoria with diffuse ectropion uvea and raised IOP. So, it was a case of left eye group E retinoblastoma with a clinical high risk factors. On MRI, there was no optic nerve invasion, and HP also suggested the same, that there was no ONE. So, no ONE on both MRI and HP. So, we went through all possible case scenarios of ONE. Going on to the results, out of 93, only 29 cases had both ONE on HP and MRI. Out of all cases with ONE on MRI, only 59% showed it on HP, and out of all the cases of ONE on HP, only 62% had it on MRI. On MRI, optic nerve head involvement was seen in 21 cases, retrolaminar optic nerve extension in 28 cases. On HP, optic nerve had involvement in 28 cases and retrolaminar optic nerve extension in 19 cases. So MRI had 62% of sensitivity, 57% of specificity, 59% of positive predictive value and 59% of negative predictive value in detecting optic nerve extension. Role of MRI is to triage basically the cases of retinoblastoma either towards neoadjuvant chemotherapy or primary enucleation. It also alerts the surgeon for possible surgical safe margins and taking long optic nerve stump. It also alerts the pathologist for a possible skip lesions and warrants a need for breadloafing. On the other hand, role of HPE stands for triaging the cases with HRF towards adjuvant treatment. As previously published, as it is a previously published data, it has been emphasized that adjuvant therapy can significantly reduce the risk of metastasis. Previously done similar studies concluded with limitations of MRI in detecting the ONE, but to our knowledge, this is by far the largest study in terms of sample size, which showed modest sensitivity and predictive value for MRI in a case of ONE. So to conclude, while the role of MRI in RB is invaluable, its utility in predicting ONE is modest. Thank you.
Dr. Yogita Gupta.
Good afternoon, everyone. I'll be presenting my paper titled Management of Retinoblastoma During COVID-19 Pandemic, Our Experience at Tertiary Care Center. I have no financial disclosures and there is no conflict of interest. COVID-19 and the imposed lockdown adversely affected the patient care services in all the departments of all the healthcare facilities worldwide. Children with retinoblastoma particularly need uninterrupted care due to few reasons like they are systemically immunosuppressed and they have fairly high chances of disease relapse. This study evaluated impact on retinoblastoma services of a tertiary care center and reports strategies used to circumvent it. This was a mix of retrospective, cross-sectional and cohort study done at tertiary care center, and records of patients of retinoblastoma attending ophthalmic emergency from March 2020 to March 21 were reviewed. The cases were categorized based on their urgency and the management were as a modified treatment protocol. And the data were recorded related to demographics, clinical profile and referral and management details of the patients. So this was the categorization used for urgency level during the COVID pandemic. Emergent cases were defined as extraocular cases of group E retinoblastoma with complications like neovascular glaucoma. Urgent cases refer to those which came for staging examination under anesthesia or cases for enucleation like group E retinoblastoma and retinoblastoma on active treatment. Then there was a category of semi-urgent cases, which were the cases on active treatment but not falling in the urgent category, or regressive tumors requiring further focal therapy, screening of siblings of a case of bilateral RB with a family history positive detected germline mutation. And non-urgent cases were the regressed cases of retinoblastoma which were completed treatment for more than 6 months, and those who came for screening for the normal eye in a child with other eye already enucleated for retinoblastoma. This was the categorization given by American Association of Ophthalmic Oncologists and Pathologists during the COVID-19 times. So we utilized a modified treatment protocol where in operating room there were minimum personnel, less surgeons allowed in the OT, and there was use of protective equipment, protective personal equipment with face shields, and also the surgical team would exit the operating room during intubation and extubation by the anesthetists to reduce crowding and reduce exposure of the healthcare professionals to the aerosols. Also, during the enucleation technique, there was gentle manipulation of tissue to avoid any spillage of blood or body fluids. Even electrocautery and diathermy was was minimally used during the muscle separation. And focal therapy was preferred over intra-arterial or intravenous chemotherapy because for IAC or IVC, the child needs to be referred to different department. So there was an idea to reduce the number of visits of the patient during COVID-19 times. Counseling of parents was done regarding immunosuppression and a risk of contracting COVID-19 during the visits to the hospital. And the role of NGOs like Can Kids was a significant contribution, and it's worth mentioning. They helped in reduction of waiting time for COVID testing at the ICMR registered lab during the COVID pandemic time. They also helped perform coordination between the caregivers and the treating team. They would also help issuing of travel passes for parents to help cross interstate borders during the lockdown. The teleconsultations were promoted. The phone device was used for audio or video call with the patients and the caregivers of retinoblastoma patients. And there was scheduling of further EUAs was done over phone by a team of teleconsultation. Also, our Hospital Infection Control Committee initiated contact tracing and isolated the COVID-19 positive cases to a designated facility in the hospital. The high-risk definition was proximity of less than 1 meter from the confirmed case of COVID-19 for a duration of more than 15 minutes for non-aerosol generating procedures, or exposure in an aerosol generating procedure, or contamination with respiratory secretion of a confirmed case without PPE. We saw 50 cases of retinoblastoma in the study. 62% were males, and there were COVID-19 testing in 47 cases. So this was the number of emergent case, urgent case, and semi-urgent case.
Dr. Yogita, you need to sum up.
Yes. So overall, there was reduction of attendance of patient of retinoblastoma by 78%. And we saw that in retinoblastoma, patients on chemotherapy, they have a risk for immunosuppression. So this triage on teleconsultation helped us to reduce the number of visits of the patients and to circumvent the problems faced by parents during the lockdown. Thank you.
I think we have one more speaker, the semi-finalist, Dr. Vishal Raval.
We have Dr. Das first. We have Dr. Seema Das is
Yeah, that will be the last, the keynote address.
So good afternoon all of you. I'll be presenting my free paper on quantitative perfusion analysis using contrast enhanced ultrasound, a novel diagnostic imaging to differentiate benign and malignant choroidal tumor. I have now financial disclosures. So as you can see in these three clinical fundus photograph, they are all kind of elevated choroidal lesions. They are all amelanotic. The corresponding B scan does show smooth dome shape elevated choroidal lesion. On just basis of ultrasound, it is very difficult to differentiate one from the another. In last 30 years, I think the OCT has evolved, even your angiography has evolved, but I think ultrasound has remained what it has been in the last 30 years. So we thought, let us explore how we can use the ultrasound in the current era with any kind of novel imaging. And with that understanding, we went ahead and studied the novelty of using contrast enhanced ultrasound to differentiate benign and malignant choroidal tumor. This was a prospective interventional pilot study, a kind of proof of concept study, which was IRB approved by our Institute of Ethical Committee. So what we did, we took a index case of choroidal hemangioma and melanoma, definitely which is a perfluoropropane gas, which is a dye which is slowly administered 1 ml followed by normal saline flush. Contrast ultrasound was used during using our routine ultrasound machine for 1 minute post injection of the dye with continuous video recording, and the image analysis was done using MATLAB software starting from 10 seconds to 60 seconds post injection at 1 second interval. So just to give the audience about understanding what is this contrast, basically this is a microbubble dye which is encapsulated in either lipid or a polymer shell. The diameter of this gas bubble is 2 to 10 microns, is less than the size of a RBC. So wherever the blood cells can circulate it.
A very good afternoon, everyone. Thank you for this opportunity. I'm Meenakshi Mahesh, and my topic is to understand the mutational spectrum associated with uveal melanoma in an Indian cohort, the first Indian gene pool study. So let me start with the patient story. This is a 30-year-old gentleman. Sorry. Yeah, this is a 30-year-old gentleman who the video is not playing. There's some issue with the video. There's some issue with the video.
Do you want to restart a presentation?
Yes, please.
ಆಕ್ಚುಲಿ ಬಲಗಡೆ ಕಣ್ಣಲ್ಲಿ ಒಂದು ಸ್ವಲ್ಪ ಏನೋ ಸಮಸ್ಯೆ ಇದೆ ಅಂತ ಹೇಳಿದ್ರು.
ನೋಡಿದ್ರೆ ನಿಮ್ದು ಪೂರ್ತಿ ಕುಲಂಕುಷವಾಗಿ ನೋಡಿ ಕಣ್ಣಿನ ಕಾಯಿಲೆಯಲ್ಲಿ ಟ್ಯೂಮರ್ ತರ ಇದೆ. ಅದು ಮುಂಭಾಗದಲ್ಲಿ ಪ್ಲಸ್ ಸೈಜು ದೊಡ್ಡವಾಗಿದೆ. ಅದರಿಂದ ಕಣ್ಣು ತೆಗೆಯಬೇಕು.
So the question that he leaves us with is, will I be safe after enucleation? So the melanoma metastasis rate shows a 30 to 50% risk of metastasis within the first 5 years of diagnosis. The liver being the most common site of spread through the hematogenous route in 90% of patients, and the median survival rate decreases to almost 4 to 5 months after a patient is diagnosed with liver metastasis. So the predictive factors for metastasis include the large basal diameter, the ciliary body tumor, extrascleral extension, the histopathological involvement features such as epithelioid type, microvascular density, and a high mitotic rate. And the PCR-based chromosome assays, which we're all aware of, where a 3 loss, 1p loss, and a 6p and an 8q chromosome gain shows predictive factor for metastasis. Cytogenetics, however, needs a larger sample, and the rearrangements tend to occur later on. But on the other side, molecular analysis is small sample sizes are sufficient for the same, and it helps in earlier manifestations. So the combination of both is ideal, and we don't have a gold standard at present to diagnose the metastasis rate of a choroidal melanoma. So what if such a predictive method was available, that too at just about ₹20,000? So the Cancer Genome Atlas divides the metastasis, the molecular melanoma prognosis into 4 classes, A to D. D having the least prognosis, where almost every patient loses their life within 1 decade of diagnosis. And these are some of the factors that have already been diagnosed and discussed in the Caucasian population. GNAQ and GNA11 have also been found in our group, and they promote cell proliferation but are not associated with survival. SF3B1 mutations, on the other hand, are prone to late onset metastasis. The highlighted factors have been found in our studies too. So the aim was to identify the novel association of the genetic analysis in Asian Indians and identify variations from the Western population. And single nucleotide variants such as BAP1, EFAX, GNA11, GNAQ, and SF3B1 were studied. So the sample was obtained either via enucleation followed by fine needle aspiration biopsy, or vitrectomy followed by fine needle aspiration biopsy. So this is a sample that you see on the left side. And 6 fresh tissue samples along with 2 controls have been studied. We have tied up with an institute called Genotypic, who are doing the next generation sequencing panel for us. And single nucleotide variants across 77 candidate genes have been studied and analyzed. So coming to the important details, we found GNAQ in 2 of our patients, GNA11 in 1, and SF3B1 was found in 2 of our patients. So the studies which have been done outside have shown that GNA11 and GNAQ, as I've already mentioned, are not going to cause a significant risk for metastasis, whereas SF3B1 has a significant risk for later onset metastasis. We've also been able to identify a few novel genes which have been recently described in uveal melanoma, such as CTNNB1, which has lower expression of the same, has reduced survival in the patients, and ZNF835 predicts the overall and recurrence-free survival in the patient. So the significance of our study is basically to prognosticate, to follow up, to give the patient a more personalized treatment regimen, to develop novel treatment strategies, and identification with a smaller tissue sample. So the future direction is probably developing a prognostic model in the Indian population, such as the studies that have been done elsewhere. So coming to my take-home messages, the patients who from our study who are on closer follow-up are 2 patients who have shown single nucleotide variations in SF3B1, 1 patient who has shown a variation in CTNNB1, and 3 patients live a low risk and reassured life. So GNAQ and GNA11 are protective from metastasis, and each sample identified few variants along with variants that were shared across at least 2 samples, which was again significant. So the future direction is basically to prognosticate and treatment based on molecular genetics in melanoma in the Indian population. Coming back to the story of our patient who we started with, this is his story, which had a happy ending.
Can we put on her slides? I think she lost a minute in the beginning.
Thank you. I'm done with it.
Okay. Nice study. My question was, why did you choose NGS versus gene expression profiling?
So basically we found that this was more easily available to us. So that is why, and we have a tie-up with them, so that's why we've started with these few samples, but we are going to, we're building a bigger database and we're trying to do other things too.
And I guess the tumors that were enucleated, another thing interesting to add maybe is to do PRAM staining, immunohistochemical staining, so that will give it a little more weight. You're going to look at it this way. So.
Sure. Thank you.
It is going to go into the area, particular area of interest, that is choroidal tumors also. And from the safety point of view, because this is a gas, it gets excreted through your lungs. So within 10 to 15 minutes, this dye usually gets excreted out of your system. So there is no inherent or absolute contraindication for this contrast dye. The dye what we use is definitely dye. This is FDA approved contrast agent used in cardiology application, particularly for left cardiomyopathy. Coming to principle of contrast ultrasound, basically it works on enhancing the backscatter from the resonance using amplification of the signals, particularly from an elevated lesion like a choroidal, where in the initial case when the mechanical index is 0.1 to 0.2, usually you see a linear backscatter, but as the mechanical index increases from 0.1 to 0.3, you usually see a non-linear resonance or a harmonic enhancement, and that is what the principle of contrast ultrasound works, where you usually see these microbubbles, they respond to this 6 megahertz ultrasound burst by showing a continuous expansion and contraction, and that is what is captured by the ultrasound transducer. So the image analysis, what we did, we selected this index patient. The region of interest was selected within the bulging choroidal lesion. The mean pixel intensity in both pre and post injection frames was calculated and was compared. We even compared the normal choroidal lesion with the area of interest just to look at whether are we seeing any kind of difference between the normal choroidal lesion and the area of interest, that is the choroidal tumors. We also wanted to study about the backscattering, that is the heterogeneity of the tissues within the tumor area, and for that we use a Nakagami analysis where we studied both the choroidal hemangioma as well as the melanoma. Coming to image analysis of the results, what we wanted to study is the M parameter and the omega parameter, which understands and tells us about the degree of heterogeneity or backscattering which happens within both the two choroidal lesions. The mean pixel intensity, as you can see, it was very high in case of choroidal hemangioma as compared to melanoma, and that is understood from our histopathology. What we know, hemangioma is a very highly vascular tumor with a very high blood flow as compared to melanoma, which is a low blood flow tumor. In terms of comparison with the adjacent normal choroidal lesion, we could see that the mean pixel intensity was very high in the normal choroidal lesion as compared to the choroidal tumor, and this is understood from our physiology, where we know that choroid is a very highly vascular to a highly vascular structure, and that's why we see very high vascularity as compared to the choroidal tumor area. This is the pre and post contrast, where you can see in case of choroidal hemangioma there is increased contrast sensitivity within the area of the lesion as compared to in case of melanoma, which is very low as compared to hemangioma. In terms of Nakagami analysis, what we could see, the M estimate as well as the omega estimate both were very high in case of hemangioma as compared to melanoma. We do understand this is a pilot study. We aim to increase our sample size, and we have tried in last 6 months increase our sample size to 10 per each arm of hemangioma, melanoma, and we have even included on choroidal metastasis. So might be next year I might be able to present the complete data, but this is what we wanted to explore and see how ultrasound can be used as a novel diagnostic marker, not only to understand the structural information, but also can give us some quantitative measurements, particularly related to tissue microvasculature within these choroidal lesions. So I conclude, I think this novel diagnostic imaging may play a crucial role, not only in tracking the alterations in tumor characteristics, but also predicting tumor outcomes post your treatment, whether you do plaque or you do TTT. Thank you.
Thanks. So Dr. Vishal, the characteristics that you see on ultrasound, which is the backscatter, depends on the type of the tumor that the blood is flowing through. Is that the assumption?
Yes. So if it is a high vascular tumor, as we all know, choroidal hemangioma is a very high vascular tumor. It is made up of very thin walled vessels. So that's why you see much more backscattering. That's why you see the contrast, the filling or the bubbles gets more within that area, and that they scatter, and you pick up that much more as compared to melanoma.
Which is a melanocytic tumor and not a vascular tumor.
Yes.
But this was the pilot case of 1 versus 1.
Yes.
And you're adding more now.
Yes, we have already added now 10 cases
Thanks.
in both the arms. Thank you. Thank you.
I think our last speaker of the session will be delivering her keynote address as the award winner for the best paper presented in the Ocular Pathology Oncology Tumor session for 2023, Dr. Seema Das.
Thank you, Akshay. Can I have the slides, please? Slides.
Can we have someone from audio visual help her, please?
Thank you, Akshay. So I'll be presenting the results of the study on the factors impacting the time to diagnosis in a cohort of newly diagnosed patients of retinoblastoma. This was the early analysis, interim analysis from the INPOC RB01 study. RB we know is the highest cure rate of all malignancies. However, in our kind of part of the world, we do see a lot of patients with advanced disease with high mortality, mainly because of the advanced stage of presentation, and a delayed time to diagnosis seems to be the major reason for advanced presentation. Time to diagnosis can be divided into parent's lag time, means the symptom onset till the first healthcare consult, the healthcare lag time or the diagnosis lag time from the first consult to the diagnosis, and the treatment lag time from the diagnosis till the initiation of the treatment. So INPOC RB1901 is a prospective multi-centric collaborative study which was aimed at assessing the epidemiological clinical features of RB in India following a prospective protocol. And there are primary and secondary objectives of the study. I'll be presenting the outcome of the secondary objective to understand the reason for delayed diagnosis leading to advanced stage of presentation in India. Rest of the study outcome is still underway for the primary objective. So all centers treating RB in India were approached to participate in this study. A standardized prospective collaborative protocol for treatment as well as follow-up was shared with the study, and epidemiological, clinical as well as the outcome data were collected. So these are the distribution of all the 20 centers which enroll patients. The study has currently stopped enrolling, and the total number enrolled has been 1120 patients. The demographic profile has been what has been reported at par with what has been reported in the global retinoblastoma outcome study, with a major chunk of the patients being unilateral and a mean age of diagnosis 2.5 years. As expected, leukocoria was the most common presenting symptom in more than 80% of the patients, and this was the stage breakup of the patient. Half of the patient presented at a stage where the eye could be salvaged, that means they were stage 0, but more than 50% of the patient presented at a stage where eye could not be salvaged. But what was also marked was that more than 20%, 23% of the patient presented at stage 3 and stage 4 disease, means at presentation they were extraocular disease or metastatic disease. When we divided the distribution of all the patients in this study across the map of the country, this is the distribution of patients across all the stages, and we see an almost uniform distribution across all the corners of the country. But when you zero it down to only to stage 3 and stage 4 patient, there is a strike difference in the north and south. So there seems to be more of advanced disease in the northern part of the country, which is also has been found in the previous other studies also, and it corroborates the finding from those previous studies. Almost 36% of the patient had to travel more than 500 kilometers to avail the treatment. This was again a striking finding from the study. And when we look at the main outcome, that is the lag time for diagnosis, these are the parameters, the parental diagnosis as the treatment lag time. Mean lag time before the treatment could be initiated after the symptom onset was 4.2 months. However, the major chunk of the lag time was on the part of the parental lag time, 44%. That means at diagnosis, when the symptom onset was noted by the parents, before they took the first consult, almost half of them took it at a delayed stage. Almost 67% of the patients were diagnosed after 1 month of symptom onset. And what was also interesting was that who was the first consult for the diagnosis? Was it an ophthalmologist or a pediatrician or a non-specialist, which includes general physician as well as the traditional medicine practitioners? That also actually kind of made a difference in the diagnosis. And majorly when the ophthalmologist was the first consult, almost 60% got the diagnosis at the first visit. However, when the non-specialist was the first consult, the diagnosis was made on the first consult in almost just about 12% of the cases. So almost 85% of the non-specialists missed the diagnosis on the first consult. We did a multivariate logistic regression to find out the factors which could predict the increased lag time at all the levels, parental level, diagnosis level, as well as the treatment level. And if we see the parental lag time, the most important factors which were significant were the mother's education or the literacy level. The socioeconomic status, of course, was there important in all the lag times. The distance travel made a difference in the initial, the parental lag time was more if the distance traveled was more. If there was a family history of cancer, again, surprisingly, the parental lag time was more, which ideally should be less, but probably is the fear associated with the diagnosis and the associated treatment made them sort of, delay the consult. Age at pregnancy, if it was less than 20 years of the mother, again, the parental lag time was more. And also, if the consult was a non-specialist, the lag time was more. If we see the diagnosis lag time, mainly is the socioeconomic status as well as the first consult with the medical practitioner that made a difference. And as far as the treatment lag time was concerned, if the leukocoria was the first symptom versus if the non-leukocoria was the first symptom, the treatment lag time was more, again because many of this patient probably was atypical presentation. Bilateral disease as a high treatment lag time, maybe this treatment needs more complex management, including chemotherapy and other modalities, which might not be available at a secondary center level, where sometimes enucleation is done. And if the non-specialist was a consult, then the treatment lag time was more. So this was the main conclusion. The treatment lag time seems to be more at the parental level. Almost 24% had extraocular disease at presentation. And what is the extrapolation formula for this study is that we should make effort for earlier diagnosis if we have to improve the outcome of RB in India, and it should be directed towards community awareness, including advocacy initiative and as well as training and awareness of the healthcare providers. Since majority of this patient, even with a low lag time, little less lag time, also had stage or group E disease at presentation, whether a more aggressive disease biology plays a role, that needs to be studied further. Thank you. These are the acknowledgements and these are the participating centers of this study.
Thank you, Dr. Das. So that concludes the second session of Oculoplasty and Oncology free papers. I would like to congratulate all the presenting authors for the excellent presentations, and I would like to thank all my co-judges for their valuable time, and for all the listeners. And sincere apologies for the next session for the delay. Thank you.